Okay.
Great. I'd like to welcome to the meeting Peter McClune, Kevin Duffy, Michael Kelly, Joe Carey. On behalf of the committee, I wish to thank you for your attendance here today. The format of the meeting is that you will be invited to make a brief opening statement, and this will be followed by questions and answers session. Before we begin, though, I'd like to draw the attention of our witnesses to the situation in relation to privilege. Please note that you are protected by absolute privilege in respect of the evidence you're to give to the committee. However, if you are directed by the committee to cease giving evidence in relation to the particular matter and you continue to do so, you are entitled thereafter only to a qualified privilege in respect of your evidence. You are directed that only evidence connected with the subject matter of these proceedings is to be given, and that you are asked to respect the parliamentary practice to that effect where possible. You should not criticise nor make charges against any person or entity by name or in such a way as to make him, her or it identifiable. Members should be aware that under the salient rulings of the Chair, members should not comment on, criticise or make charges against a person outside the House or an official by name. Can I also remind members and witnesses, please to turn off your mobile phones or put them onto airplane mode because it causes absolute havoc in here. I also wish to advise that any submission or opening statements you provided for the committee will be published on the committee website after this meeting. So the first person I'd like to call to make a presentation is Mr. McClune, please.
Chairman.
Oh, sorry, Mr. Duffy. So I beg your pardon, Mr. Duffy.
Okay, thank you, Chair. I'm joined here today by my Commission colleagues, Peter McClune and Michael Kelly, and by Joe Carey, who's the head of the Secretariat at the Commission. The Commission is happy to take the opportunity to contextualise and discuss its recent report and to help this committee in whatever way we can in its work. The Commission was established to advise Government on public sector remuneration policy, and in that regard it has a broad terms of reference. In May 2017, the Commission published its first report providing input on how the unwinding of the financial emergency measures in the public interest FEMPI legislation should proceed. In this second phase of the Commission's work, we were obligated by our terms of reference to undertake an examination of whether and to what extent there are difficulties in recruiting and retaining staff in key areas of the public service which were identified in our first report. The broad frame in which we operate requires us to take into account current government policy on public service pay, including the planned pay restoration provided for by the Public Service Stability Agreement, the general backdrop of fiscal sustainability, and the many competing priorities for public investment. We were also aware of other developments in respect of the Public Service Pay Bill, such as new entrants pay and the settlement of the consultant's case. Given the very specific terms of reference for this phase of our work, we adopted an evidence-based approach to all of our considerations, and we believe the conclusions we have drawn are well-founded. It is clear that the 2009 moratorium on recruitment and promotions in the public service had a significant effect on numbers in the public health service. The Commission recognised that the reductions during the period up to 2013, which across the nursing and midwifery grades was 9%, bringing the numbers to 33,676, and acknowledged that the level of demand for services did not reduce and has noticeably increased over the last decade, with an increasing and ageing population. There is evidence that numbers have increased since 2013, although at the end of 2017 the number of 36,777 is still not at pre-moratorium levels. Submissions to the Commission confirm this increase is not simply as a result of the lifting of the moratorium, but also required the development of a range of initiatives to both attract and retain healthcare workers. An early and very positive conclusion is that medicine and nursing and midwifery remain very attractive as career choices, if we judge by the popularity of these courses among young people at university entry stage. 9.6% of this year's 57,000 school leavers have selected nursing as their first preference, with a further 5.6% choosing medical undergraduate education programmes. This means that this year, in common with many recent years, the available places on nursing and medical education programmes are oversubscribed. We continue to produce high-quality graduates in numbers which should meet our domestic needs. Indeed, Ireland produces the highest number of medical graduates per capita in the OECD. We are also attracting significant numbers internationally. However, we are seeing some retention problems, and Irish-trained graduates do not seem as inclined as previously to return here after having taken up international appointments. We realised very quickly that Ireland is going through the same experience as many other health systems internationally. Healthcare skills are in short supply, and all indications are that such shortages will continue. We are facing sizable challenge in attracting and retaining competent practitioners as a relatively small player in a highly competitive global market for health skills. The Commission acknowledges that numbers working in the public healthcare sector have increased since the lifting of the moratorium on recruitment. However, there is evidence of both recruitment and retention difficulties over recent years in the groups that we examined. Much attention has already been given to resolving these difficulties, and the Commission referenced and drew upon the findings of other relevant reports on the various aspects of these complex challenges in reaching our conclusions. We also noted that we are now beginning to see a positive impact from many of the measures already taken. Some examples include offering permanent contracts to nursing and midwifery graduates, increasing undergraduate places, improved access to training, and flexible working hours. A huge amount of work has already been done, often in a collaborative framework, but from our analysis, there is no room for complacency. We are saying very clearly that recruitment and retention must continue to be prioritised, and we point to a number of areas where policy and practice needs further strengthening. In particular, the Commission reiterated its view, put forward in its initial report, that measures need to be put in place to address data gaps which exist in collecting and analysing the transactional data necessary to monitor, manage and maintain an adequate and appropriate workforce. Our work was informed by many sources, direct evidence provided by the parties, and a review of international published work and domestic publications, including the Sláintecare report. It points to the need for integrated workforce planning as a major input to future service planning and delivery. This more rigorous approach should lead to a more reliable basis for planning workforce requirements and measuring more definitively where any possible recruitment or retention deficits may be. We did find evidence of some small pockets of this discipline and practice, and very early indicators are positive. We invited submissions from employers and staff representatives. In the absence of consensus on the scale of the problem, and more particularly on the likely solutions, we commissioned our own independent research. We looked at destinations, conditions of employment in the main host countries, and an opportunity was provided to staff for direct input via survey and interviews. We acknowledge that the response rates were low and that the results may reflect a group with different views than the generality of the cohort surveyed. Therefore, while needing to be treated as indicative, they are nonetheless informative. A consistent finding from all of our research is that the decision to take up a particular post or to remain with a particular employer for a prolonged period is influenced by a multiplicity of factors. These factors include the extent to which mentoring facilities are provided for new entrants, the degree of staff engagement within the employment, the relativities of remuneration, access to training, and the promotional opportunities available. Chapter 5 of our report deals with this in some depth, and chapters 6, 7 and 8 include some of the key findings with regard to attitudes to recruitment and retention from the survey and interviews for each of the groups. Based on our analysis, we have identified a number of measures for consideration in relation to each of the three groups we examined. These include strengthening HR functions, a funded multi-annual workforce plan, an increase in certain allowances, and a reduction in the service requirement necessary to reach the grade of senior staff nurse. We were also mindful of the commitment in the Programme for Partnership Government to full implementation of the McGrath report to assist in the recruitment and retention of key medical staff, and endorsed the recommendations contained in that report. Turning specifically to mental health care, which is this committee's area of concern, the Commission's report highlighted specialities within the mental health care area which were experiencing particular difficulties with regard to recruitment and retention. We found that among nurses, the psychiatric staff nurse and the intellectual disability staff nurse grades recorded the most significant average annual decline of any nursing speciality between 2013 and 2017. We also concluded that while there is a general difficulty recruiting hospital consultants, with more significant problems in certain specialities and locations, psychiatry in particular was a speciality highlighted as experiencing recruitment challenges across a number of indicators. We believe that the recommendations we have made should have equal relevance in mental health services as in other areas. The Commission, however, stopped short of making sector-specific or speciality-specific recommendations due to the wide nature of our mandate. We hope, Chair, that our report will be helpful to your committee in its work, and we are happy to clarify any aspects of what I have just outlined or our findings for your committee.
Thank you so much, Mr Duffy. Let me just explain what's going to happen now. I'll be passing you on to the members of the committee here. Each member, the first 4 members, will have 7 minutes each to ask you questions and for you to answer. Just before that, though, Deputy O'Loughlin has kindly agreed that because I have to leave at 2:30, that I can have the first question, if that's all right. So I'm really going to actually make more of a statement than a question. I first of all acknowledge that you think that this should be applied, the report and the recommendations should be applied right across the whole mental health services and physical health services. I absolutely understand that. But we also know how difficult, the huge challenges and difficulties that we are facing in psychiatry. And really, this is just a comment from you, if you don't mind. I was in Waterford the other day, and I was on the Greenway cycle path, and I met 7 psychiatric nurses who are retired, and they're all younger than me. And I said to them, are you ever asked to come back and help, because we have such a shortage? And they said they're asked all the time, but that they would never do it. They would never go back, for one reason only. Their hours are 10 to 12 hours a day. And in that environment, which is very difficult, in the first place, it's a very difficult environment, but also the environment itself, and I mean the building itself, is also not conducive to staying there. I'm wondering, was that part of your remit to identify that hours need to be checked, need to be looked at, and that the same staff are being used over and over again, which is going to have an enormous impact on their own mental health?
Well, first of all, I think what you say, Chair, just confirms what we found and as the report points out, that there's a multiplicity of factors that cause difficulty, and they relate to the physical environment in which people work. It can relate to in some part, the conditions under which people work, and in some areas of the country are less attractive to people to work in than others. So there's no single issue that you could focus in on and say, if we solve that problem, that totality of the problem is solved. There's a whole package of measures that need to be looked at. And that's what we tried to do in this report. Our terms of reference were broad. We were asked to look at were there problems of recruitment and retention, and to what extent did they exist. And we were also asked to look at what were the factors that may have contributed to them. And as you and your colleagues will see from the report, we've identified a whole raft of them. I'm not going to take up the time of the committee by going into all of them. But the hours are specifically difficult for staff to cope with. Sorry, Mr. Kelly. Go ahead.
Sorry, I think did you want to say something?
We did recognise that there was a need to address the question of flexible working hours, and that is one of the recommendations that's in the report, is that the HSE and employers generally should recognise that if there is greater flexibility, there's a stronger prospect that you will either retain or attract people back into the workforce who are, because of their own circumstances, only available on a limited basis. Yeah. So yes, that's one of the recommendations that we have made.
Thank you, Mr. McClune. Did you want to say something, Mr. Kelly?
Same point, and in fact the thinking around that came from a question we asked ourselves in relation to agency staff. The question we asked ourselves is, why is that regime relatively more attractive to a lot of nurses, midwives, than a full-time position? And the answer around that is at one level it is around pay and increments and so on. Another part is pension contribution and not having to pay that. But the third part is about flexibility, and it is about the freedom to work a more flexible regime. So absolutely, in fact, our own statement in the report is, a nurse providing a contribution in a flexible way on ours is far more valuable than a nurse not participating in the workforce. So absolutely, the modalities of it really are a matter for discussion between the parties. We couldn't get into that.
So, Reid, I'm going to pass you on to Deputy O'Loughlin now, but just to say that obviously, possibly the answer is to reflect an agency model where they have flexibility, better pay, and they don't have to reduce their income because of a pension, etc. I mean, just simply, just to look at that from a solution-based approach. So, Deputy O'Loughlin, please.
Thank you very much, Chair, and thank you to Mr Duffy and to the witnesses. You've done very valuable work, certainly, in relation to the report that you have prepared for us. Just a few key observations and questions, if I may. And I think it's very interesting, when you talk about the number of this year's school leavers who have looked at careers in nursing and in undergrad medical programmes, and basically roughly 5,000 young people chose nursing, or wanted to choose nursing. Obviously, these areas are oversubscribed, and about 2,500 opted for a medical undergrad ed programme. So we don't seem to have a problem attracting young people to come in to the area, and the country, the state, is spending a lot of money in ensuring that these young people have a very good third level education experience, and that they come out as very well qualified young people. But obviously the key issue here then is ensuring that they have the opportunity and wish to stay in our country and to enter into the services where they are absolutely so badly needed. And I think there's certainly a lesson in that. We're not doing enough, obviously, within the country to ensure that these young people become part of the necessary and essential workforce here to look after and care for people. You identified some particular areas that are coming up as problems, and not particular remuneration. And interestingly enough, we had the Psychiatric Nurses Association in here, and they suggested that subsidised accommodation should be offered to nurses to mitigate the high cost of living, particularly in the Dublin area. So I'm just wondering, is that something you could see as a possibility? And also just asking you about geographic trends that you established in terms of non-retention of staff, and of course the obvious link to the cost of living and availability with housing. In terms of remuneration not being the main issue, you did speak about the mentoring, staff engagement, access to training and promotion as key areas that could possibly be looked at. Certainly I think there are areas that we should look at, and just if you have any more guidance in relation to those areas. The area that obviously we are particularly concerned with is the whole area of attracting professionals into the mental health services, and it is particularly disconcerting when we see the decline in the numbers of the psychiatric staff nurse. And then you did mention the whole intellectual disability area, which I have a particular interest in myself as well. Do these sectors potentially need to look at increased incentives because we absolutely need to be able to increase our support nurses and staff in this area. My colleague, Deputy James Browne, highlighted during the summer that the numbers in terms of attracting, and we're down about 90% in terms of people that we should have. So we have to, this is absolutely at crisis point. And, you know, with our ageing population, and I need to ask this as well, what monies have been set aside to deal with increasing number of diagnoses of dementia? And that can lead into the whole mental health area. And we know that people with intellectual disability can obviously, there is difficulties around dual diagnosis, but they obviously can have mental health issues. So there's an impact there between all of them. As your report indicates, the European Commission estimated a potential shortfall of around 1 million health workers in the EU by 2020. And Irish health care staff are very much in demand abroad, because it is recognised that we have a very good training system here. And the fact that many of our emigrants show little desire to come back to return and Sláinte care itself emphasises the urgent need to plan our workforce better. Do you think we're making any progress in this regard? Because this is absolutely key to what we're saying. I'm not sure how many minutes I have left. Where am I? Sorry,
you have 2 minutes left.
2 minutes. No,
to hear the answers as well.
Oh, well, okay. I'll finish there then. Thank you.
All right. Who would like to answer that?
Perhaps we all would, but no, there's a number of very, very important points that the Deputy has made, and if we can just deal with some of them, and some of them we've addressed in our report. And 2 points I think that are quite important, and I would ask the committee to emphasise, you know, to look at our report and see the emphasis we've placed in these 2 points. First is that the reality of the situation that we were confronted with is there's an absence of data, reliable data, on what vacancies are there and where they are. Now that's a problem. And we suggested a solution. And the solution is that we need adequate workforce planning. That isn't there at the moment. And those 2 factors are of huge importance and are central to the recommendations that we have made. At the moment, there is very little in the way of planning, for example, to deal with expansion in the demand for services, and very little in the way of planning to deal with retirements, or the fact, and it's a reality, and it's always been a reality, that people you recruit, a certain number of those are always going to leave. That's always going to be a reality. It's depending on how you count the figures, the retention rate, about 7% or 5%, depend on whether you count retirements as people leaving or not, will leave. Now, some people would say that's not huge in terms of the overall numbers, and certainly it wouldn't be regarded as huge in what you see in the private sector and private sector employment. But it represents a very significant loss to the health service, and it represents a very significant loss in terms of the investment out of public funds that have been put into training those people. So the more we can reduce that number, the better. And we've suggested certain incentives in the nature of allowances and so forth, and increased opportunities for promotion as a way of perhaps encouraging people to stay who might otherwise leave for a whole variety of reasons.
To move you on, Mr. Duffy, because we're running out of time.
All right, I'm sorry, Chair, but maybe my colleagues might want to augment what I've said, because there are a number of other points.
It goes, I understand completely the anxiety to improve our chances of recruiting more psychiatric nurses and psychiatrists and indeed other staff across the mental health service. But if you on the research we have looked at, right, Kevin has already mentioned, this is the decision to stay with a particular employer is multifactored. The decision to leave is multifactored. When you look at the impact of the moratorium, at one level it reduced numbers, but actually for people who remained, it left a more difficult work situation. And when you look at the responses of people, some out of the workforce, some still in the workforce, and indeed people who are working abroad, about their perspective on working in the Irish healthcare system, the one thing that comes through consistently is the pressure of overcrowding and understaffing and the personal and professional pressures that puts on individual practitioners. So as part of the solution to this is actually to try to get the service right. And I know a lot of work, and indeed the work this committee is doing, but a lot of work is going on the ground in trying to do that. And I do see there's a kind of a catch-22 here, because if you don't have the people, it's difficult to do that. But I think the various pieces of it actually have to happen in tandem. And you know, if you were to ask the question, you asked the question about subsidised housing, that, you know, intuitively attractive in sort of geographic areas where you have a particular shortage or whatever, but no matter what way you disguise it, it is part of a remuneration package. There is nothing wrong in looking at that, but it needs to be looked at as part of that wider spectrum of issues that need to be resolved. And hitting at one in isolation isn't going to solve the underlying problem.
Okay, thank you for that. So I'd like Deputy Buckley, you're going to be taking over in about 10 minutes. So if you'd like to ask your questions now and get your answers within 7 minutes, please.
First of all, welcome, and thank you for the presentation today. I just have a few very brief ones, really. A bit of frustration as well, because this recruitment and retention, you mentioned it earlier on, Mr. Duffy, about being oversubscribed when it came to, you know, positions for nursing, when we have a total I suppose swallow hole of emptiness when it comes to looking for specific staff in areas within the mental health section. And I can't understand, it's like how would I put it? If you need a pound of sugar tomorrow in the shop, you go for a pound of sugar. If you need 2 pounds the day after, you go and you buy 2 pounds of sugar. We're on about forward planning. And if we know that there's going to be a shortage in the coming years, because you mentioned about retirement and so on, and you're going to get so many that will leave as well, that will not stay in there, why are we not training more staff? Why are we not giving them better opportunities? And you mentioned about demographics as well. It kind of put a little light in my head and said, why can't we plan? I mean, even in my short term here as an elected rep, I've been following this probably for the last 14 or 15 years. And for the last 14 or 15 years, everybody that comes into a committee speaks about the problems. And nobody speaks about the solutions. And why can we, when we know the demographics in certain areas, we know where teams are fully staffed, we say within the CAMs and where they're not, why can we not specifically pick a specific area and say, right, our plan for the next 2 years is to fully staff this area. Put in the resources, and if you move out of Dublin, you'll notice that rents and so on are a lot cheaper, obviously, than Dublin. But we should be forward planning for that. I'd like to have a model in Southampton in the hospital there, where the staff that work there have cheap accommodation on campus. These are solutions, but nobody comes up with it. I mean, you mentioned as well about, you know, the examination in detail of recruitment and retention. Yet there seems to be an awful lack of, I suppose, evidence, you know, within the very little detail. If you have very little detail, you mentioned evidence-based, how can we get evidence-based? I mean, can this commission, can it actually provide details, you know, of the health service employers' engagements that took place and what grades they actually examined? Is that possible to get that? And I was kind of struck by one of the lines here. It says that the PSPC will not take place of direct negotiations between government and employee representatives. You know, you mentioned about the FEMPI a while ago. I said, well, if you're not engaging with it, what is the purpose of the Commission's report on that? And finally, again, it's a statement. You're on about recruitment and retention, and it was very, very worrying that part of another report that was attached to documents today regarding CAMS and the 57 units that were investigated. It was frightening to find out that 79% of the units that were inspected were non-compliant. 69% were non-compliant and deemed to be higher critical risk to residents, not among staff, and 51% of the regulated services were non-compliant on an ongoing basis. So there's one area that is absolutely toxic, and if you're expecting somebody to put their hand into the boiling pot without cooling the water, we are in trouble. And it is a bit, and it's not a personal attack on you, but it just goes to show again the system that, in my view, the presentation is here again is all the problems and no solutions. We need solutions. We're giving them. Will there ever be a day when somebody will actually grab the bull by the horns and say, right, in my own area in Cork, it's a disaster when it comes to CAMS. Right, it's a huge population, staff it, and move on to the next county, and the next county.
Exactly. Thank you, Deputy Buckley.
Point. The thrust of our report.
Sorry, Mr. Duffy, we've 3 minutes to answer this. If it's okay.
The thrust of our report is to suggest solutions to problems that we've identified, and I just commend you to the report. With regard to the other matter that you just referred to at the end, I'm not aware of that report, and it doesn't seem to be a matter that came within the ambit of our terms of reference. The matter about the quality of accommodation in places. I suppose thirdly, and very briefly, the fact of the matter is that there are more applicants for places than can be accommodated. The number of points required to get into nursing or to go into medicine indicates this. And there are proposals in the report for additional training places. Obviously, there's a great number of people who want to be nurses and doctors, and they can't become nurses and doctors because they can't get into the training places. So we do believe that there's a need for more training places. And taking the point that you make, Deputy, it's a good one. I mean, the whole purpose of manpower planning is to recognise or identify the number of people that may leave, the number of people that may retire, or the number of people who simply may decide that they don't like that career and go off somewhere else. And proper manpower planning will anticipate that. And that may well mean that if you require 1,000 nurses now, right, you should be training more than that number so as to accommodate vacancies that will inevitably arise down the road. So that's the whole thing about manpower planning, which I said is central to the recommendations and the solutions that we try to identify.
Thank you, Mr. Duffy. Did you want to say something, Mr. McLoone, there?
Yeah.
Very briefly.
Well, very quickly, I mean, this is just another report on top of a lot of others. And at some stage, committees like this have got to look at our report, and if our recommendations are endorsed, then there's a stronger chance that they'll be acted on. But the one thing that this service does not lack for is reports that are full of analysis. So it's a question of how do you pull this together and say the Commission has got certain aspects of this right, and if these things are endorsed and acted on, we won't be talking about the same issues this time next year.
It's been an absolute repetition on our part that there's 12,000 reports, by the way, and many are doing exactly what you're doing, and we're also looking at the retention and recruitment. So thank you for that. I'm going to ask Deputy Buckley to take over from me. Thank you so much for attending, and thank you to the members for letting me go. And sorry, Deputy Kenny, you'll be the next person to ask questions. If you just hold on one moment while I swap. Thank you.
Right. Okay. The next questionnaire, I suppose, next speaker on this is Deputy Gino Kinney.
Thanks, Chair.
And,
apologise for being late. I was at another engagement. I think it's one of the narrative that we've seen on this committee about retention of staff in the health service, and I think it's a crisis. And I think some of the questions has already been answered. Just to kind of about issues of retaining staff. Obviously, it's not just about pay; it's obviously about working conditions. Because I worked in the health service at a previous time, and I know how really stressful the job can be in that environment where you're dealing with sometimes life and death, and you're dealing with very, very stressful situations. So it's a difficult job, and the burnout rate is quite high in some ways. I know friends of mine that are psychiatric nurses or general nurses, and they find the job extremely rewarding. They don't do it for the money, but they do it to give something back, and they love the job, but they find it extremely stressful on the wards, wherever. And I think, that's probably comes with the job, but I think it's probably more amplified than it ever was because of certain conditions that are in the health service and cutbacks and all that. I just wanted a question on other jurisdictions. I'm sure other kind of jurisdictions around the world have probably the similar situation of retention of staff. And I'm guessing, we all think that nurses are going over to Australia, but I'm sure Australia even have a situation where they can't actually hold on to nurses. I just wonder if that's the case. And maybe other jurisdictions where, particularly in Britain, where they, in order to keep staff, they have incentives about rental accommodation, where rent is quite very, very reasonable in a very kind of costly kind of rental market. So, is that possible in a situation where there's actually a housing crisis in Ireland? I don't know if that's possible. Can there be a kind of an incentive for retention of staff, particularly with staff that have emigrated but want to come back? They look at the balance sheet and they say, do you know what? It's not worth me while come back over, because it's cost of living and so forth. But is there a way that the government could, make provision for that, particularly around accommodation? And just the last question on a kind of a general overview, and I'll probably ask this question to everybody that comes here, but how bad is the situation now? How bad can the situation be in the future? Can it get a lot worse? And to make it a bit more kind of complicated, how good was the situation before? How did we get to a situation where staff were hemorrhaging from the health service? As I said, there's numerous reasons why this happens. I think there is some. I think most of it is down to pay. But why have we come to this situation? And how bad could it go? Where obviously, if you have a situation where there's non-retention of staff, I've seen this when I was working, where you have lack of coordination, you have lack of clarity, you have lack of familiarity with patients, that can have a very major detrimental effect on service users and the health service in general. So I know that's kind of a bit of a scattergun, but particularly around the jurisdictions of retaining staff, and how is the situation? Could it get worse?
Well, I think to put it in context, you raised the question, Deputy, about where did all this come from? I suppose to some extent the moratorium on recruitment and retention, or recruitment and promotion in the public service generally had a major impact. I mean, that's when numbers went from almost 40,000 down to 36,000 or 33,000. So there was a huge loss there. People retired, weren't replaced. People left and weren't replaced.
What year was that? 2011?
That was 2009, I think. Was it?
Yeah, the period from 2008 onwards to about 2013, you would have seen a very sharp decline in numbers employed.
And that was across the public service, and that was in consequence of the fact that the country was in the economic state that it was in. But that's a fact, a huge factor. And we're still trying to catch up. That's the reality of the situation. That the moratorium was lifted But that didn't mean that people were going to fall out of the sky into positions. So it is going to take time. The indications that we've received in the course of our work is that things are improving. That's set out in the report. Perhaps not at the pace that everybody would want, but they are improving. Can they get worse? Hopefully not. But then the factors that caused the problem in the first place, perhaps nobody anticipated either. But right now, there are measures in place, a lot of measures in place, which are intended to ensure that the numbers match the needs. You're right in what you say, and this came across to us from surveys and from submissions that we received. The stressful nature of the job almost has a self-perpetuating cause, in that people are working under pressure. Perhaps they get sick. They're out of work. That puts more pressure on their colleagues. And that's a feature of the health service, probably in every health service. The report makes clear, or all of the evidence available to us confirm this, that difficulties of recruitment and retention are a feature of practically every health service, no matter where. And to some extent, that's why Ireland is competing internationally to get people to come in here, because some people are leaving here because they're attracted to other countries that have difficulties. So it's an international phenomenon, not by any means confined to Ireland. But of course, our remit is to look at the situation in Ireland and to suggest whatever solutions we can identify for the Irish health sector. Colleagues have anything to add to that?
Well, mobility is a feature of nursing and medicine now that when I was a nurse many years ago wouldn't have been as strong. So when we looked at the period from the lifting of the embargo on recruitment, it was noticeable that it was underpinned by quite a number of initiatives that were taken by the HSE and employers generally to try and attract nurses to come and work in their services. So we're depending on the domestic market, and we're also taking people from abroad. And if you look then at what the Australians and the Canadians and the US are doing, they're probably coming here to try and attract both medical and nursing staff away from the Irish health services to work in their jurisdiction. So this is why we've recommended so strongly the idea of a workforce plan that's funded, and that this is something that is not been put in place before. We have evidence that in 2017 there was an initiative taken with general nurses and midwifery with an oversight group that achieved about 80% of the target that it set itself. So our view is that something similar needs to be developed on a national basis, funded for about 3 years so that we have that certainty, but that it should also apply to intellectual disability, to mental health and to other areas, that it shouldn't have an exclusivity around the general or midwifery. Not that they're not unimportant, but that the plan should address all needs and all areas of the health sector. So your question about predicting can it get worse is one that I think we shouldn't hold our breath and wait. We should recognise that we need to put plans in place right now to ensure that not alone will the trend of recruitment and retention improve, but that we have plans in place to make sure that the needs of the citizens will be met in the future. And certainly if the ambitions of Sláintecare are to be achieved, these measures need to be taken now, it seems to us.
Just the last supplement. You're saying about obviously the embargo, and obviously that's had a kind of legacy issue up to today, obviously, you know, the austerity years and so forth. and the Irish Health Service not only lost thousands of beds, but obviously lost thousands of staff, and it's playing up catch-up. It's a bit like the housing crisis, you know, it's almost kind of a similar kind of vein. So are you saying that, this is probably not a state secret, but the Irish Health Service is probably devoid of at least 6,000 to 8,000 frontline staff, frontline nursing staff, or has that, you know, obviously the embargo has been lifted, there's more people coming into nursing, but at the moment there is definitely, there is a lack of frontline staff in the Irish Health Service.
Well, what was evident to us was that in the period of the moratorium, the demand for services did not diminish, it actually increased. And the Sláinte Care report, right, referenced the issue of the ageing population. So when you look at the period over the last number of years, you have all the evidence that you want available to show that demand for services has increased, and that's what's created the stress that you referred to earlier, Deputy, in your own experience. It's hard to quantify what the need is from our perspective, and this is again why we put such emphasis on the need to workforce plan, because this is what allows you to define what services are required, what are needed, and to engage with what resources are required, whether they're nursing, medical, or ancillary staff, or support staff, or other skills. It's clear, just to give you a figure, that we're still just over 2,000 below the figure for nurses that was there in 2010. Right, so if it was 39,000 in 2010, we're just over 37,000, despite all the initiatives that have been taken. So we still have a way to go to get back to where we were. But I'm sure if you got back to that figure, there still would be an argument that that's not sufficient to meet our current and future needs.
Thank you. Are you happy enough with that, Deputy Kennedy? Oh, sorry, Mr. Kelly.
Okay, just one comment, and I think, you know, we shouldn't lose sight of the fact that a lot, you know, the concern about this is shared, for example, by health employers within the HSC and onwards department and deeper, and a number of the things that are already happening around, for example, sorting out the new entrant salary scale. In other words, this process that's underway at the moment of looking at the more recent entrants and seeing what needs to be done around that, and offering permanent contracts to new graduates. I mean, a key thing in this should be to recruit everybody coming out of training into the Irish healthcare system, and hopefully retain them there. So in our thinking forward on this, what we were trying to do is to try to envisage what are the additional pieces you could put in place to reinforce that if we succeed in attracting these young graduates in the first instance and then retaining them. So what we put forward is a number of additional steps which are designed to reinforce things, good things I have to say, that are already happening. And we're hoping that, okay, if they are acted upon, the combined impact would be to make, because ultimately what we're trying to do is make the Irish healthcare system a more attractive and enjoyable place for professionals to work.
Thank you very much. Are you happy with that, Deputy Kenny? Thank you. I now call on Deputy Neville.
Thanks. Sorry. Thank you to the witnesses. It'll be a bit of an over and back, if you don't mind, and if my questions are a bit out of kilter, just let me know, because I do apologise for being slightly late. Just in relation to your findings, right, your terms of reference here, phase 2, you've said that to produce a final report to the Minister by the end of 2018. Are you working on a final report, or is that your recommendation that you should do a final report?
No, we've dealt with the health sector, right, in the report that you now have.
Okay.
There are other areas that we have to look at. Right. And the final report will deal with other areas
And that
We've
final-
already, this is, if you like, an interim report
Okay.
to deal with the health sector. So,
So the
we're-
final
we're
report
finished
will
with
be by
the
the end
health
of this
sector.
year. The final report will be by the end of this year, yeah?
Well, that's the target. That's what we've been out to do.
And how do you feel, do you think you'll make that target?
Hopefully.
Yeah.
Hopefully. I mean, we can't predict. I mean, the interim report was supposed to be available in the end of June, I think. And
Right.
because of difficulties in getting data and various other factors.
What kind of difficulties did you find in getting data? What
Well,
stumbling
some of it
blocks did you
simply
find?
isn't available.
Can you give me an example of what may not
Well,
be
for
available?
example, there isn't a database of positions that need to be filled.
There isn't a... Sorry. Well, I'm just a bit perplexed that there isn't. So there's no specific database of positions either broken down by CHO or by subspeciality. There's no specific database of positions to be filled.
Well, you'll find good pockets of information, but what we found is across the system, what you'd love to find is that there is, you know, a very good matrix out there in relation to demand and similarly in relation to supply. And for example, when you look at retention, one of the things you'd like to find is that there is a good understanding, which is documented, of the reasons why people leave, and some analysis of that, so that you can begin to work on the measures. Now, there are pockets of good information around all of that, but what we didn't find was a comprehensive data set that you could actually go into.
Can I ask, with the greatest respect to you, you're obviously just telling us what you're finding, like this is not a throwing you, but there's a centralised HR service across the HSE. Do they not have that data?
I think it's important to say that was a problem we had. And one of our recommendations is that it be rectified. That information should be readily available. Not to us, obviously, we've done our work, but it should be available to managers in the system.
Right,
People
because we
should
have
know.
been presented with figures here of staff shortages where there are by CHO. So when you were actually, when you asked for those figures, that was obviously manager driven to actually get those figures, those specific figures. Were you able to get those specific figures?
We got figures from various sources, right? What I think we were saying, what my colleague Michael Kelly was just saying there was, it's not possible to tap into a definitive database and say they're the number of positions that need to be filled. That isn't there.
Right, okay, no problem. Secondly, in your report, are you going to streamline where you think maybe the quick wins, maybe the medium-term wins and the long-term wins are? Because some of what we have been presented here, like I think it was 26 or 28 steps to hire a psychiatric nurse, if I'm not mistaken, and obviously that's just completely cumbersome. Will you, in your report, will you be tiering where you can see the quick wins?
Well, we finished our report, Deputy.
Yeah.
I mean, you have it.
Right,
that is the report.
Yeah.
And as I'm sure you've seen in the report, we do highlight that problem.
Right.
And do suggest ways of dealing with it.
Right, okay. It's just to try and see what, I suppose what we're coming from is to try and tier where there's quick wins. And where, look, the likes of the IT systems need to be changed. Okay, that's going to take longer. But 27 or 28 steps can be cut pretty quickly. That's kind of the basis of the questions. Just to go back there in relation to recruitment retention, in the other jurisdictions obviously that are in competition, we know it's a global marketplace now. You know, prices of flights are cheaper, it's easier to get to places, and all that has a knock-on impact or a knock-on effect. Can you just, for the basis here, or if you do know, what are the top barriers outside of pay that are stopping people from coming back? Outside of pay, let's push pay aside, because oftentimes people, I know myself from a recruitment background, pay obviously is an extremely important factor, but it may not be that nub that stops people from coming back. I mean, we can't compete in Australia because Australia's got natural resources and they can pay people more of those natural resources that they sell. Same with the likes of the Middle East. So you're trying to find the other softer sides outside of pay that you can find that maybe we might be able to compete with. I mean, we had car insurance before, obviously the price of rent, all these sort of things, but have you identified what maybe might be the top? But again, I'm trying to find, like, I'm trying to ascertain quick wins in how we market to our graduates, or how we market to our immigrants who are...
There's a whole variety of factors, and, you know, trying to rank them is difficult, but ones that were readily identifiable were, first of all, career opportunities. People want career progression. Now, we've made recommendations on that, right? For an awful lot of people, bearing in mind that the vast bulk of nurses are women, flexibility can be an issue. Flexible working hours can be an issue. That was touched on earlier by the chair, right? And initiatives should be taken there to try and make it more attractive for people to come back and work. Training opportunities, because most people who work in the health sector want to develop their skills and their abilities, and that in turn helps in terms of career progression. So training, in-service training, is important. But there are a whole raft of initiatives that are being taken that need to be developed further. But the ones that come across most, or came across most in our deliberations, were the ones that I have mentioned. And I think initiatives there. Obviously, there are other factors, and they too have to be looked at. But it's generally a question of trying to make it more attractive. There are other issues, leaving aside altogether people who leave and you're trying to get them back again. The Irish Health Service is dependent, as are other health services, on people who are trained somewhere else, people who are trained in other countries, and getting them in here. Now, there are a number of difficulties there that delay the process, such as, and they're clearly necessary, need to verify people's qualifications. They need to verify, in some instances, their actual identity. There's Garda vetting needs to be done. And one of the things, and I go back to the point that Deputy Kenny was referring to earlier in terms of the effects of the embargo. The embargo didn't just affect the numbers recruited in direct healthcare provision. It affected the totality of the public service, including the administration services within the health service. So there are shortages not in terms of the personnel department. There's often difficulties in having the numbers of people to set up competitions, to verify the qualifications of candidates, to do the various other checks that need to be done. They're all problems.
I agree with you that, but I mean, on the flip side of that, has management not grown? Management level in the HSE, has that not grown?
We didn't measure the management level, but the fact of the matter is that it's self-evident that in many areas they haven't gotten back to the pre-moratorium levels of staffing. Whatever about stripping down the frontline staff during the moratorium, ancillary service were really hit. So I think the answer to your question is there are still difficulties there. And if you're going to intensify external recruitment, well then obviously you need staff to organise competitions, you need staff to deal with all of the, what we could call the infrastructural things that need to be put in place to get the person, even if you identify a candidate, to get them to the point where they're in a ward and doing the job. And they're all difficulties. They're not insurmountable difficulties, but they are difficulties.
You happy, Neville? Thanks. Thank you. Look, I'm conscious of time here as well, and we have 4 more members here, and obviously the next section here will be, you'll have 4 minutes each, and we'll give to members the last 10 minutes to answer back. So I call it in the Rotors. Deputy Rabbitte, you're actually next.
All right, thank you, Chair. Thank you, gentlemen, and Joan, for your presentation there this afternoon. Much appreciated. I'm going to continue on from where Deputy Neville left off, because he was exactly on my vein, because I was going to ask about ICT and data. First and foremost, one of my questions is, and these are snappy sort of answers, like, how long did it take you to get the data, and could you go to one direct point to get the data? So that's a yes or no. Could you go to one direct point?
No.
No.
No. All right. So how many sources of points did you have to go to get the data?
Sorry, John.
Approximately 40. 40. Thank you. So we have one HSE and we have one HR department that governs it all, but we had to go to 40 different sources to see where we had our gaps in relation to recruitment and filling of positions. Correct? Thank you. That's shocking, because you talked in about that the embargo was possibly one of the worst things that had actually happened. To me, what is the worst things that I'm seeing here today is that we don't have a central base for knowing exactly where the gaps are in the system, to be quite honest with you. It's not embargo we should be focusing on, it's on the management skill sets to actually identify where we need to have people working in the various places around the country. All right. Mr. Kelly, you spoke about something that I believe passionately on. I want to know about your essential workforce and increased incentives. Like, I passionately believe that as they are qualifying, we should be enticing those young persons in. We should be making them permanent straight away, those who make the cut, and then we should be allowing them their 2 or their 3 years break to travel the world if that's what they so wish, and then come back to their permanent job again. Have you teased out that idea? Yeah, as a recommendation, as an incentive?
Well, it's not. In fact, we didn't have to make that recommendation because the idea of the permanent contract is already in place.
Yes.
That is a recently implemented measure by HSE, which means that every graduate coming in is offered a permanent contract at the point of qualification.
But how many are you recruiting directly from the nursing schools? Because I know down in Galway that, or in Limerick actually, it was in Limerick, where all the nursing staff that were approached in Limerick, we had a very high take-up on it. I'm just wondering, on all the various nursing schools, where is that being managed out, and how did you find that on your report?
Yeah, I don't have the exact date on that, but in terms of things that can be done, right? I'm just saying to you that the permanent contract is already in place. Seems to me a second thing is, and I won't dwell on it because I've already mentioned it, is sorting out the position about the sort of revised pay scale that was introduced in 2012, and again, there's work afoot in relation to that. Kevin has spoken about, in answer to the question, what sort of things would actually help to make a career in the Irish health system more attractive, and I think they are about. But all the evidence coming back to us suggests it is about professional development opportunities, career development, and so on. So when you do see the growth in the number of specialist posts in nursing, advanced nurse practitioners, and so on, that's all part of that construct. And I think the more work that's done, and there's a lot of it going on, to look at the new areas in which nursing practice can be expanded and so on, and to action that. And obviously
that's the word there, Mr. Kelly, it's to action it. So in relation to what we talked about there, the professional recruiting of the nursing there at the moment, and that was just as a part of, that was announced in the last 18 months. When you were doing this review, how many of the nursing schools were approached and how much of it was actioned, is what I would like to know.
Stop it there, because I'm conscious of time. I
sorry.
just want to get in. If you can park that answer, and what we'll do is, for the last format, we get the remainders of the speakers.
Well, see, sorry, Chair. Yeah. We focused an awful lot about how the negative effect of the embargo, and I take that on board. This was a positive action that was introduced in the last 18 months, and I would like to know that was it measured as part of the Commission, because when you're going back to 40 different sources.
Deputy Rabbitte, you will be getting the answer, but I'm just conscious. I just want to give everybody else a fair time, and they can come back. They'll have the last 10 minutes to come.
Thank you, Chair.
Thank you. The next speaker on the agenda will be Deputy Seán Crowe.
You're all very welcome today, and I suppose I'm as frustrated as yourselves, and I'm listening to the members here in relation to the lack of data, the fact that you had to go out and create your own evidence seems bizarre, you know, and I think it reflects on the service, and I don't think it made it any easier for you to try and carry out the work that you were being asked to do by the government in relation to it. The lack of availability of essential data, you were saying about the low response rates between, you know, no consensus between employers and employees. And that you had to go out and that caused difficult for you. But how can you arrive at the conclusion then that some areas are facing recruitment and retention difficulties and others are not, when you don't actually have that data as such? And then, you know, the Minister is saying that it's not, you know, it's not a pay review but a response to a pay-related response for some areas but not for others. Allowances are recommended for some areas but not for others. And again, that's sort of curious. So if we don't have a full picture, it's very, you know, it's almost where, you know, you're getting impressions that this needs to be done right. And again, you're saying that, you know, there appears to be a lack of evidence that recruitment and retention issues were examined in detail. So maybe, you know, in the couple of minutes you have, could you provide us with details of the health service employer engagements that took place and what grades were examined in detail? And there's a couple of other stuff, like, you know, given the issues of pay inequality across the public sector, including healthcare, is there a case for restructuring of pay scales in order to make entrance levels more attractive while not further inflating higher wages levels? Junior doctors, entry-level consultants. Again, you know, they seem to be, you know, far less pay, but also they seem to work harder. And does this cause unsustainable levels of, you know, and make it more, perpetuate the idea it's making it more unattractive arrangements at that level, and is that turning people off? What kind of cost of living measures are needed to address and it was touched on here by Gino about the London rate, you know, do you see that, you know, should it be a Dublin rate? Again, you know, we had a meeting over the summer there with CAMS in Ballyferm, and they were saying that was part of the problem, that people, you know, where do people stay, where do people live, where do those nurses go? So they're living 2 hours away from Dublin, 3 hours away from Dublin. It's not sustainable. So, you know, how they've managed in other jurisdictions is that the accommodation comes with the job. So maybe that's something. The reliance on agency staff, how does that affect retention and recruitment? Because again, that's part of the difficulty. And part of the big problem we have is that even today, the Taoiseach was asked about, you know, the amount of nurses within the system, and he's saying, you know, compared to other jurisdictions, you know, we probably have higher amounts, you know, per bed. But nurses don't just deal with, you know, patients in bed. There's a higher, you know, there's the whole range of issues that we need nurses for. And there's almost a denial of the fact that there's a crisis there within the service itself. It was a bit like the debate last night in relation to housing. So again, did you pick that up in your discussions, in your inquiries, in your work in relation to that, in your inquiries into what you were asked to do by the Minister? Thank you.
Thank you, Deputy Crowe. I know there's a lot in it, but you will have the 10 minutes after to try and filter through these. I call Deputy Carey, please.
Thanks very much, Chair, and you're all very welcome here, and thanks for your presentation and information. Just say, in relation to, you make reference to a positive impact of a changed approach to trying to get graduates on board, trying to get them at source, offering those contracts. You know, having the proper training. You know, when you looked at this, how far did you go back in terms of, did you look at the percentage of graduates that are actually opting now to go into the Irish Health Service, as to when, you know, what type of percentage is there now? You said there was a positive impact of that change approach by the HSE in terms of recruiting graduates directly. What quantifiable change did you identify in the report? I'd like to know that, because I think if we are to be serious about trying to hold on to people, we need to do it from the very start and make it attractive for those graduates who have gone through our system here of education that's highly regarded throughout the world. You know, there's, as you said earlier on, there's recruiters coming here from different other countries. So I think if we can champion that and make it attractive for graduates to come out of college and to work within the health services that we have here, I think that's the way to solve it. You know, and you've mentioned, you know, say having more undergraduate courses. Has that happened? You know, is there an availability of those courses now, and to what extent, you know, have they increased? Are they available throughout the country, or is it specified in particular parts of the country? But I think it would be interesting to know the amount of graduates that are coming directly from college into the health services now, as opposed to, you know, before this approach. And obviously our state has come through you know, a very dark period through the economic crisis, and we're in a better place now. You know, but you know, people are coming back as well. So maybe you might be able to answer that for me.
Thank you, Deputy Carey. I'm conscious and right on the button. Senator Devine, you were right on the button, as you were right. You were next anyway. So.
Oh, great.
I'll give you a couple of seconds to draw your breath.
Yeah. Billy Buster, vote. Thanks, listen, sorry I missed a good bit of it, but obviously can't be helped. It's, I suppose, apt that today you're before us and the P&A and the INMO are meeting to discuss the Commission's report elsewhere in Dublin today, and how nurses are going to react to it. I think overall in the report, and you've kind of changed in your own presentation here today, but I think you've ignored the recruitment and retention, and maybe that's the intention now, is to get onto that section of what's required for in particular our health service, and that's what we're here for, mental health nurses. A lot of deputies and senators had asked about the future of mental health services, the future of staffing, in particular nursing staff in the health service. You've said there's over 2,000 vacancies at the moment. In mental health alone, there's over 700 vacancies. 88 in St Itas, 76 in St James's, 56 in Dublin North City, 62 in Galway and 46 in Louth Meath. Have you factored in not just this, but also how Vision for Change, its implementations, its future developments, with only 30% obviously implemented so far, but that we need over 700 nurses just to stand still, and never mind the implementation of the 70% recommendations that are outstanding of Vision for Change. Have you factored in as well the retirement potential of 1,752 nurses immediately and over the next few years? That's shockingly 34.2% of mental health nurses in the country. It's unsustainable as it is, but looking at those figures, it's quite depressing, I think, for the future. And we alluded to what caused this, what started it. There was different stuff. There was the yellow pack grade that was offered to nurses some time ago that successfully we defeated. Tony O'Brien at the time saying, or just after, shortly acknowledging when the hemorrhage started, that we forced them out. That was a quote from him. The moratorium was shooting ourselves in the foot. Everybody should know that health should not be affected, because we've seen from the moratorium of almost 10,000 nursing posts gone, the mental health care needs of our population, and significantly of our children who grew up, or were born and grew up in those last decades or whatever, the suffering that has compounded, and the demand that is compounded, and we can sustain it. We're not matching it. We've €300,000 per week spent on overtime. That's 2 million annually for nurses in mental health alone. It's not sustainable. I suppose if if you could, we have 200 increases since last year of vacancies in mental health nursing. They're arguing that nurses say that shortages are best addressed by across the board pay rise for their grades, and yet you have given what is it, 20 million increase of allowances targeted at small. Well, it would be a small enough area, but across the board, nurses are demanding it. He's saying that people are leaving. There's just a report out today, a survey funded by the Health Research Board of medics and staff in Australia, and 36 out of the 51 interviewed have no plans to return due to the broken health system and the misery that they have in the health service. The focus is on salary as well. We had a presentation to the committee there a while ago, prior to the summer, which
Senator,
showed.
I'll have to cut you short.
Okay, which showed that
and you have a vote.
The pay here, given all the other external factors, does not match the pay elsewhere. So we're I suppose we're still in. We haven't got there, and I said 34% to retire in the next 5 years is shocking. The 37.5 hours that was given to nurses following different industrial disputes, and it was given, when is that to be reinstated? Because in some cases they're still working 1 day free extra per month. Have you referred to that in the pay commission? It was the comment of the chair's long hours that nurses are working, and it's 13.5 that nurses are working. Nursing students, I welcome the increase in the graduate nursing students. Unfortunately, there's no mentors within the hospital, Senator, with the experience to actually mentor them. So we have young nurses, not yet competent, running wards of 35 people. So we have that hemorrhage to really address of our experience. And they're not returning. I have lots more, but obviously my time is limited. Thank you.
Thank you, Senator, for patience, and I'd like to welcome Deputy Louise O'Reilly. And Deputy Louise O'Reilly will be very brief. She just has 1 or 2 questions.
Thank you, Chair.
I'm conscious of time.
Yes, I have one question, and welcome to our guests, some of whom I will know very well, some not so well. It's lovely to see you again. And I have a topical issue, so I'm going to have to leave, so I'll be very brief. 2 things. Are you aware that the INMO have just recommended to their members that this Commission report be rejected? Number 1. Literally just now, so you may not be, and that's fair enough because you've been in here, but could you comment, and if this has been asked already, I can check back on the transcript and that's fine, but the Minister for the Minister for Finance said in advance that this, and as part of his submission, that this was not a pay review and could not be a pay review. So in light of the fact that we now have a rejection by a very large group of workers within the public service of this particular report, or indeed a recommendation that their members will reject. They haven't had that ballot yet, obviously. In light of that fact, could you explain to me what influence the Minister had over the conclusions in relation to the fact that he seemed to start off thinking it wasn't about pay? We have a significant group of public sector workers now who say it is very definitely about pay. There's allowances within the report, and clearly they are paid, because there's none of us divide up our wages into that's allowances and that's not allowances. It's just your pay. It's what you get at the end of the week. And I'm just wondering if you could comment on that, on what influence what the Minister said had in relation to the final conclusions, which appear to have not found favour anyway, but certainly one group. Thank you, Chair.
Deputy, I am very conscious of the time. You possibly have about approximately 4 minutes. You're probably not going to be answering them all. Right. But even a quick, snappy ones.
Maybe to start with, Deputy O'Reilly, good to see you again. Did we know about what decision the Irish Nurses and Midwives Organisation took? Obviously we didn't. But we were aware of the fact that they were meeting, but I'm not going to comment on that. That's their decision and their prerogative. In terms of the Commission is independent, right? But it's not at large in the sense that it can do what it likes. It's obviously circumscribed by its terms of reference. And the terms of reference didn't enable the Public Service Pay Commission in this module to act as if it was a pay review body. That's a fact. And I think it's also important to remember that the genesis of this phase of our work can be found in the Public Service Stability Agreement. It was a collective agreement, right? And that's the job we were to do. It wasn't a general review. But we did make suggestions, because we recognised in this report, and this is something, unfortunately, there's been a lot of comment about the Pay Commission having rejected the nurses' pay claim. We did nothing of the sort. We didn't reject the pay claim on its merits. We didn't feel that we were in a position to consider it, but we did say it should be considered. That has been lost, unfortunately. So, I think they're the two main points you made, Deputy. If there's any point that I've missed, no doubt you'll come back to me on it, but I think they're two important points.
Thank you. Thank you very much.
Very briefly, Chair, on other points that were made, Deputy Rabbitte raised questions about the numbers of undergraduate places. They're set out in our report. I'm not going to read them because time doesn't allow, but they're actually in our report on tables 6.1 on page 61, and they're there to be seen. In terms of monitoring numbers and getting people in, one of the initiatives that were taken independently of anything we recommended was to set up an oversight group as a consequence of an agreement reached between the nursing unions and the Department of Health. And that done quite good work in trying to identify where vacancies were and the numbers of people that should be recruited to try and fill them. One of our recommendations is that oversight group should continue. The other point in terms of I think it was Deputy Rabbitte's point about how did we come up with figures around the numbers if in the absence of data. As my colleague Joan has told the committee, we had to look at 40 sources. It wasn't that we didn't get information, it was difficult to get it, and I think in terms of Deputy Neville asking what was the delay, it was the difficulty in actually having to go to a multiplicity of sources to get the information. On the latter points that Senator Devine has just made, quite frankly, none of the figures that you've stated there were before our commission. We didn't. Nobody talked to us about figures like that. And I'm not so sure where those figures come from. But we do acknowledge that there are difficulties in the mental health area. We acknowledge that. It's in the report. And we suggested initiatives that could be taken to at least ameliorate those difficulties, not to solve them, but to ameliorate them at any rate.
Thank you. And Deputy Crowe mentioned there a number of things on recruitment, data, the living measures, the employment engagements, the London rate.
Well, you see, a number of... it's also important, I think Deputy Crowe himself made the point. The Public Sector Pay Commission wasn't set up as an alternative to the established mechanisms for determining pay and conditions of employment for health service workers. That, happily, is a system of collective bargaining. We're not going to usurp the functions that are well established between trade unions and employers. So, we're not an industrial relations body. We weren't given that task, and I don't think that people in the trade unions or on the employer side would thank us if we were to usurp their function and try and do their job for them. a lot of those things are matters that will be dealt with in the normal course on a day-to-day basis within established collective bargaining mechanisms. And we're not going to usurp that. Nobody's going to let us. Nobody's going to let us.
It's about, you know, you're talking about recruitment and, you know, you're talking about those, particularly those at low pay, you know, does that have an impact on people staying within the service and so on? So you can make recommendations in relation to
Well, what we've said in the report, and I think this again is important, we said that pay in and of itself is not the only issue. We didn't say it wasn't an issue. We said it's in and of itself. And that again perhaps has been misinterpreted by people who have commented on our report. So we did make some recommendations on pay, and we did recommend, and I emphasised that, as I told your colleague, Deputy O'Reilly, we did say that there is a grievance, there's a sense of grievance amongst nurses about their pay levels vis-à-vis that of others. It's not just confined to nurses, isn't it? And we did say that this needs to be looked at as a separate exercise. So, you know, I take your point, it's a holistic approach that we're trying to get at here. But, you know, we had to work within the parameters of our terms of reference. And as I said, we couldn't go beyond that. So all of these issues are there, and I've no doubt in the fullness of time they will be dealt with. And we have made such recommendations as we felt that we could make and were justified in the report.
Just very briefly, Mr. McLean, if you just don't mind, if Deputy Brassil just wants to come in, very briefly.
It's been a kind of crazy day around the place for meetings, so my apologies for being late. And if the question has already been asked, I'll revert to the chair for the answer. But in this whole issue around retaining staff, retaining graduates, and then attracting graduates back, is pay, in your opinion, the primarily issue, or is the work standards, workplace, workforce planning, that type of issue, a bigger issue or the same? I mean, I suppose if you were to advise us as to how we could best tackle this particularly difficult issue, what would you be advising from your experience?
Well, just to deal with that, Deputy, I understand exactly what you're saying, and all I would say is that the report deals with the totality of what we see as the difficulties that are out there, right? And what we said in it was, and I just made the point to Deputy Crowe, pay in and of itself is not the totality of the problem. There are other problems as well that have to be put right. Insofar as rates of pay, I mean, you can see from the report the international comparisons, and I'm not going, time doesn't permit me to go into all of that, but our conclusion was that if you gave everybody a significant increase in pay in the morning, even if that was possible, and of course we couldn't do that because our terms of reference didn't allow it, you would still have all the other problems that need to be addressed. So it's a holistic approach that needs to be taken. And there are structural difficulties that need to be addressed in terms of workforce planning and in terms of providing access to data and information on where vacancies arise in anticipation of vacancies, and trying to make the job more attractive for people who we might want to encourage to come back into the system. So we've tried to set out in our report what I could only describe, as I said, as a holistic approach to a multiplicity of issues.
Thank you, Mr Duffy. You're okay with that, Deputy Brassil? Yeah. I just finally saw on the last point that Deputy Crowe mentioned Mr McClune and finally Mr Kelly. Thank you.
Well, it's just that debates are always complicated by the presence of pay problems. But recognising your own terms of reference having to deal with recruitment and retention in the mental health area, this report contains a number of important recommendations, in my view, that hopefully will be of assistance to your committee when it makes a further report. But I couldn't overemphasise the importance of the need to develop a workforce plan. Because I'm 40 odd years around the health services, both as a practising nurse and working as a full-time trade union official. And we've stumbled from year to year for so long that it's time now that we recognise that new, different measures are needed that focus on what our workforce needs are. And in a global competitive market, we need to engage with that challenge very much so. Those actions need to be taken now in the next number of months, otherwise this will be yet another report that goes on another shelf, and the discussion will continue as it has for years, around the problem and analysis of the problem, but no steps taken to solve it.
Thank you. And finally, Mr Kelly.
Very quickly, Chair, I think it was Deputy Neville earlier on was asking, are there obvious things that could be done and don't necessarily have to take a lot of time and that are reasonably well defined. And I just wanted to mention three. The one Peter McClune has mentioned is the first one, the funded workforce plan. It's fairly basic and bedrock. The second one is follow-up in relation to NCHDs on the McCraw report. There is a well-defined agenda there in terms of 4 specific things that need to be done, well identified, and they need to be actioned. I'm not saying they're simple. I don't go into the detail now, but well defined. And the third one, because we haven't mentioned the position of psychiatrists at all really during the discussion today, but the gap that remains and will remain for newly starting consultants and some of those recently recruited consultants. It's something we put our finger on again in the report, and it needs to be addressed in some way, and it will need to be addressed because it sends a very loud message back to non-consultant hospital doctors training here or abroad. If we don't get that right, that's the way we looked at it. There's a big message in it. Not easy, but it's got to be done.
Thank you very much. As we're coming to a close, look, I suppose, first of all, I want to thank you all for attending today. It wasn't easy. It's never easy, but we certainly will take everything on board. And I mean, there was a lot of useful information here today, and it will certainly help us with our committee work. So, and I don't envy your own work. So, as the joint committee is now adjourned until Wednesday, 10th of October 2018 at 1:30 p.m. Thank you very much. Thank you, Chair.